Alrighty, welcome everyone. Thank you so much for joining us today. We are very honored to have you all with us today for part two of our Geographic Atrophy series, webinar series. Thank you guys again for tuning in. My name is Michelle Georges, and on behalf of the Carroll Center for the Blind, we want to sincerely thank Apellis Pharmaceuticals for helping us make today's session possible by sponsoring our two-part series. So thank you, Apellis, and for everyone who's made part one and part two possible. Now, before we begin, I would love to take a moment to just go over a few housekeeping items. To start, we are offering ACVREP credits, and you will need to email development@carroll.org by the end of the day and provide the entrance and exit codes for you to get credits for today's session. I will provide the entrance and exit codes at the start and finish of the presentation. Our entrance code is STAR, 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 and I will provide the exit code before we log off this afternoon. Now, as you may have heard, our session is currently being recorded and will be shared with everyone after the fact. So if you'd like to take another listen to today's presentations or you know someone who missed it, it will be available in just a day or two once our team has it ready for viewing. We do currently have the question and answer Q&A feature enabled on this session, so we encourage you to pop all of your questions into the Q&A chat box, and we will try our best to get through as many as possible at the end of the session after both speakers have completed their presentations. If we don't get a chance to get to your question, we promise we will write it down, ask the presenter for their answer, and share it back with you via email. Now, without further ado, I would love to take a moment and welcome our very first speaker of the session, Dr. Marisa Tieger. Dr. Tieger is an experienced vitreoretinal surgeon and clinician and currently serves as a member of the retinal faculty as an assistant professor of ophthalmology at Tufts University School of Medicine. Dr. Tieger, thank you so much for joining us, and I'd love to kick things off to you.
Great. Thank you for having me. So as Michelle mentioned, I'm a retina specialist. I do surgical retina and medical retina here at Tufts. I also cover Newton Wellesley Hospital. And I'm going to be talking to you today about the treatment for geographic atrophy. So I know you had another talk here. Let me actually unpause my screen here. I know you had another talk recently by one of my colleagues about geographic atrophy in itself, but just to give us some background here, when we talk about macular degeneration, we have our wet and our dry form, also maybe called exudative or non-exudative. We're going to be focusing obviously on the treatment for the dry form. Within that dry category, there's early, intermediate, and advanced forms of macular degeneration, and within that advanced group, we divide that into the group with subfoveal geographic atrophy and non-subfoveal geographic atrophy. And so what does that mean? Well, what is geographic atrophy? This is the advanced form of dry AMD, causes progressive and irreversible loss of central vision. It's a localized, sharply demarcated atrophy of the outer retinal tissue, RPE, which is the retinal pigment epithelium, and the choriocapillaris. And in this picture, you can see clinically what we see when we look in and see geographic atrophy in that lighter area, whereas the tissue is lost. And on our autofluorescence image, this is really highlighted. It's darker on our autofluorescence image. And so geographic atrophy starts in the perifoveal region. And what does that mean? That means when we look in the back of the eye, the center here, you have your optic nerve, and then you have your vessels coming off your optic nerve. This whole center here is called the macula. And within the macula, the very center is the fovea. And so geographic atrophy starts perifovea, so next to the fovea, and then it expands to eventually involve the fovea over time. And why that's important is because the fovea is where our crisp reading vision comes from. And we need our macula, again, for our central vision, where we're looking at people's faces and things. Macular degeneration never affects your peripheral vision, but it's this loss of central vision. So as geographic atrophy progresses, you end up with these central scotomas, is what it's called, and those are these blind spots, and it's this permanent loss of your visual acuity. It's typically bilateral, and there's over 8 million people that are affected by geographic atrophy, and it's approximately 20% of all individuals with macular degeneration. So when we talk about that subfoveal, non-subfoveal group, so these are some pictures of some scans that we do when patients come into the office. This is an OCT scan, and it gives us this cross-sectional view through the back of the eye. These are the layers of the retina here. This is our choroid beyond the retina, and the black area would be the area inside of the eye. And the fovea is this depression here that you see, this dip where the arrow is pointing. And so this area that's highlighted with our yellow bar here is our area of tissue loss. You can see that we're getting that hyperreflectivity coming through because we've lost tissue in the retina. And we've lost these two bright bands that we have here in the area that doesn't have atrophy. But this is non-subfoveal because our fovea, this very central area here, is spared. And on the bottom, this is subfoveal. So right in the center here, we have this atrophy. And that obviously is going to impact visual acuity dramatically. You can see here these lighter patches. These are the patches of atrophy in this picture. The dark gray is the healthy retina tissue. And so what geographic atrophy likes to do is it kind of expands in a ring around the fovea and then eventually spreads in to knock out the fovea. And so why do we want to treat geographic atrophy? It's because of this progressive and irreversible vision loss. And as it progresses, this is kind of that diagram, you start to lose more and more of that picture. If you're looking at someone's face, more pieces of that become missing until it eventually spreads into loss of the center when you hit the fovea. And so how long does this take? Well, we know from some natural history studies that this usually is about 2.5 years from the initial diagnosis. And so time is of the essence, when we're talking about treatment, we want to make sure that it's going to prolong vision as long as possible, but we also want to, look at the rate of progression. So when patients come into my clinic and they have atrophy, I usually monitor this with autofluorescence imaging and OCT and see them back every 4 months to get an idea of what the rate of growth of these lesions are, because it is variable within patients. So once again, you start to get these patches, this is what patients see. They might be looking at their grandchild, for example, and part of the face is missing here, which corresponds to that area of tissue loss. And this patch will get larger and larger as the geographic atrophy expands. Let's see here. This is just a diagram of that. So geographic atrophy impacts our patients' lives. It limits their ability to drive. A lot of patients feel they are not safe to do that anymore. It impacts their ability to read, and it impacts their ability to live independently. A lot of patients feel ultimately when they're losing their vision that they need assistance, and it's really about patients' quality of life and maintaining independence. When we're talking about measuring the impact of geographic atrophy, we can't go with vision alone because the fovea is, involved pretty late in the disease course. And so when we're looking at these patients, we're using these autofluorescence images and, we're looking at other things, OCT, to see how these lesions are spreading because the vision may remain excellent up until the fovea is knocked out, at which point it's permanent and we can't reverse those changes. And so this is an example of a patient that you can see over the course of 2 years, these patches slowly expand, but the fovea is still uninvolved, which is why the vision remains excellent. So what treatments are currently available? So most of the treatments that we'll talk about today are complement inhibition. There were 2 approved medications starting in 2023 by the FDA, and those 2 are both injections into the eye. And they're both complement inhibitors. So what is the complement system that we're inhibiting? So these are a group of proteins that help the body fight infections. There's 3 different pathways with different activations. And this system is important for our immune system. It can help kill bacteria, viruses, and it promotes inflammation. And so there is evidence, there's histologic, physiologic, and genetic evidence that the complement system is involved in geographic atrophy, which is why this was chosen as a target for potential treatment. So when we're looking at the two medications that were approved to treat geographic atrophy, we're talking about a C3 and a C5 inhibitor. So you can see C3 is a little bit earlier in the pathway and C5 is a little bit further downstream. Pegcetacoplan was the first medication approved. That's also called Syfovre, and that's your C3 inhibitor. And then ACP is blocking further down at C5. So how are these drugs administered? So these are intravitreal injections, which have been, used for many conditions for a long time. And this is the, hallmark therapy for wet macular degeneration or intravitreal injections. But this, is obviously relatively new treatment when it comes to the dry territory. And so when this medicine is administered, the eye is numbed topically with either drops or ointment or an injection of numbing medication under the conjunctiva, which is the lining over the white part of the eye. A cleaning solution is administered as well. And then a speculum is put in to keep the eyelids away and the eyelashes away from the eye, away from the injection site, because there's a lot of bacteria on the eyelids and lashes. And then a small needle is used to go through the sclera, the white part of the eye, avoiding the lens and injecting the medicine into the vitreous cavity, which is this orange cavity you see in the back of the eye. And then, the speculum is removed, the cleaning solution is irrigated out. The whole injection process, only takes a few seconds. But the idea of injections, especially for patients who have had, the dry form and haven't needed it in the past, can be a big barrier to starting treatment. So this is a video that's an example of what an intravitreal injection looks like. We're going to turn the sound off here. And so this is an image of the eye here. You can see the white part of the eye. That's the sclera where we're going to be injecting. And this doctor is marking a safe distance away from the cornea. And that's to make sure that you're not going too far back into the retina where you could cause a retinal tear or a detachment, and that you're not going too far in the front where you could hit the lens. And this is the needle going into the eye and injecting the medication. And this is slowed down. It's actually usually a lot faster than this. And you can see the medicine's injected into the eye here. And then the needle will be removed. And sometimes a Q-tip is placed afterwards to ensure that there's no leakage, but most of the time that's actually not even necessary. All right, so this isn't a case example of a patient that was treated with Syfovre or pegcetacoplan. This is an 80-year-old man who had bilateral non-subfoveal geographic atrophy. And you can see that in the study eye, one eye was treated, one eye was not treated. And when we, look 2 years later, the study eye has had pretty minimal growth of the geographic atrophy, these dark patches, compared to the untreated eye that was not treated here. These dark gray patches have expanded. The geographic atrophy has expanded quite dramatically. And so this was one of the patients included in the initial study. So what do the studies show? They've showed that pegcetacoplan or Syfovre reduced geographic atrophy growth by up to 42% in non-subfoveal and subfoveal eyes over 36 months. This came from the Gale study. And so you can look here. Oh, or I don't know why it's going forward. Let's pause this. So you can see here, these patients were either dosed every month or every other month. And there was a 28% reduction in the non-subfoveal group with every other month. And then subfoveal was 25%. This is the other study. This is the GATHER2, which looks at ACP, the other drug. And the way that these patients were dosed was every month in the first year. And then this was expanded to every other month in the second year. And This also showed a reduction in geographic atrophy growth. It was lower numbers, about 14% reduction in the every month and actually 19% in the every other month. But this drug was not approved. It didn't meet its endpoint for the every other month. So it's only approved for monthly injections, whereas Syfovre is approved for monthly or every other month injections. In terms of safety concerns with these medications. So there's a few things we worry about. The biggest being there's a 1 in 10,000 risk of a very severe vasculitis that can occur after the first injection. And when that happens, it results in almost complete vision loss in that eye. The other risks that we worry about, there's about a 7 to 8% risk in most of the studies of choroidal neovascularization. This GATHER2 study had that risk closer to 11% here. And what that is that's converting over to the wet form of macular degeneration, where you have abnormal blood vessels breaking through and bleeding, and then you would need treatment for the wet form as well. And then, there's also risks of endophthalmitis, which is an infection in the eye, and that's true for any injection. And beyond that, there's a very low risk of retinal tears or retinal detachment with any injection as well. But the study showed no higher rates with these medications than a general injection. So again, looking here, this looks at our pegcetacoplan or Syfovre, looking at the rates of wet macular degeneration. And again, we do have a risk of CNV that should be discussed with patients before starting. The retinal vasculitis, this wasn't observed in the clinical trials. This was noted after this was approved by the FDA and available to the public. And so it's a rate of between anywhere in 1 in 4,000 after the first injection to 1 in 10,000, depending on the literature. And so again, something important to discuss with patients. When I'm using these medications, I'm typically using them in patients that have lost the fovea in one eye and they have geographic atrophy in the other eye. And so the way that I'm approaching this is I actually use the eye that the fovea is lost as a test dose eye, so that if they were to lose vision in one eye, it would be the eye that already has poor central vision. And if there's no reaction and there's no inflammation at the 1 month visit, then I start treating the other eye, and I feel much more confident that they won't have a reaction in the other eye that still has good vision. I tend to use more Syfovre or pegcetacoplan than Izervay because of the every other month dosing. I think it's a huge burden to bring patients in indefinitely for monthly injections. And so I think that is one benefit of using Syfovre. But again, it's a patient decision ultimately with which medication they're more comfortable with. And then the other thing that I always tell patients is that, they should be taking their AREDS 2 vitamins as well, which, we'll talk about. Historically, the AREDS study showed that these vitamins were protective in terms of converting over to the wet form of macular degeneration. But they did a retrospective study that showed that they actually may also be beneficial in terms of slowing geographic atrophy. Because this was retrospective, we have to take it with a grain of salt. And so they are doing a prospective study to see if this is in fact true. The AREDS 2 formula, there's a lot of different brands. Preservision is one, Ocuvite, Ivite. So any brand is okay as long as it has the actual studied formula, which involves copper, zinc, lutein, and xanthine. And this retrospective analysis looked at fundus photos, which in itself can be a little problematic because it's a little harder to judge. So hopefully the new trial will actually use autofluorescence, and they looked at overall growth and growth towards the fovea. And they did find a slight reduction in growth towards the fovea. Again, it's a very small amount. They didn't find any change in overall growth, but it's promising to suggest that, this is a medication patients should already be taking. And there's, a chance that it could be beneficial, not just for decreasing your risk of converting over to the wet form, but also decreasing the geographic atrophy risk. So I do recommend that all patients continue on this. And I stress to all patients that they should continue their Amsler grid monitoring as well, which is a graph paper chart that patients should test, at least once a week with each eye with reading glasses on. And that way they'll notice if part is missing or newly distorted, because that could just be expansion of geographic atrophy, but it also could be conversion over to that wet form, which is critical to catch early, because earlier treatment means better visual outcomes. So with that, I am completed my slides here. And so I think we're going to be doing questions actually at the end, but I'm defer over to Michelle.
That was great. Thank you so much, Dr. Tieger. That was a lot. And so we really appreciate you kind of taking the time to explain all that. I'm sure there will be some more questions coming in. As a friendly reminder, please do take a moment to pop your questions into the Q&A chat so that we can, collect all of them and ask both presenters at the end. Before we move on to the Q&A portion, I would love to welcome our second speaker, Tina Lafford. Thank you so much, Tina, for joining us. Tina is a certified vision rehabilitation therapist and is also the Carroll Center for the Blind's Director of Community Engagement and Outreach. So she works very closely with all of our clients and many other community members who are interested in learning more about our programs, and has a great background in understanding all the best services to help individuals throughout any part of their journey. Tina, thank you so much. I'd love to hand things off to you.
Thanks so much, Michelle.
Perfect. All right, my little square just highlighted green, so that tells me that my microphone is working, that folks can hear me, whether or not you can hear me well. Hopefully it sounds good on your end. So as Michelle noted, I am a CVRT, a certified vision rehabilitation therapist, and I always like to at least make sure that folks know what that is. So often we hear terms like physical therapist or speech therapist, occupational therapist, and folks know, oh, I know just what that is. But what is a vision rehab therapist? And what we do is we specialize in the rehabilitation in all skill areas for a person who is new or has experienced additional vision loss. And we are teaching adaptive methods for completing familiar or perhaps novel activities. That can be anything from technology, learning Braille, cooking, painting your nails or dyeing your hair, shaving, or participating in really fun recreational activities from sensory arts like using a jigsaw and a power saw. That's not my specialty, so don't ask me to teach you. Or playing cards. We want to make sure that everybody is well-rounded and is feeling good and is able to really continue participating in their community and in their families as they did prior to their vision loss. And so my discussion is a lot different than Dr. Tieger. She shared a wealth of knowledge in terms of treatments and what is out there. And so there are lots of treatments, there are lots of options. And I want to make sure that if you're waiting for different treatments and options, that you also know that rehabilitation, this non-medical model, can also co-occur potentially for various consumers who are experiencing vision loss, whether that be through macular degeneration or other eye conditions as well. For example, many folks are very familiar with eye exams. It's medical in nature. You use your insurance card and you check in and reimburse through medical insurance. But what about a functional vision assessment? And so that's one thing that we specialize in at the Carroll Center, is helping you understand not necessarily your visual condition, but how you function with the vision that you do have. If you have a lot of low vision, would you potentially benefit from soft yellow lighting or very bright white lights? Do you benefit from contrast, magnification? How about the use of a CCTV or a handheld magnifier? What we do at the Carroll Center in our low vision clinic is, although we use the word clinic, not clinical necessarily in nature, as it's not a medical appointment, but it's a functional appointment to help you and your family members better understand your vision and how you can use it to the best of your ability at home or at work or both. And so you might be thinking, all right, it's not a medical appointment. I've now learned about a VRT. I don't know what this is. How do I start advocating for these things? And one thing I want to make sure is that you have the knowledge of what to advocate for. So you might be in a doctor's appointment and you hear numbers like 2100, and you're not legally blind yet, or you're experiencing some vision loss, but you might be struggling. Let's see what's going on in 6 months or 2 months from now. And what I want you to think about is not just those factual numbers, but your function. Right? Could you ask for a referral to for a functional assessment to see us, or to see a low vision optometrist who might be able to work with you on understanding that low vision? It's If you're struggling to complete activities of daily living, you're struggling to read or get to and from work, you're struggling to complete work tasks, reach out. There are different resources out there, and it's not just from Massachusetts. Obviously, Carroll Center is located in Mass. We are unfortunately not in sunny Florida or California, but there are agencies like ours across the country that are there to help support folks who are struggling with their vision loss. And there are specialists, across the country who want to help support you. If you're not sure where to turn, you can always reach out to us and we can help connect you to different specialists in different states to the best of our abilities, or at least help point you in the right direction to your state's agency. And why I want to make sure that everyone gets connected who is struggling is because it's really important to note that although there is so much hope and there are cures and there are treatments, that co-occurring can often be that emotional adjustment and potentially isolation. And I think it's something that isn't always talked about as openly because it's really personal, and it makes us feel vulnerable and uncomfortable perhaps. But when we don't have the right resources and we're not connected in ways to others who are experiencing something similar, we can feel really unsure of where to go next, or to whom we should be reaching out to, or is my experience something that others have had? Is it normal to not be able to see my cell phone or put on my mascara? Is it weird that I still want to wear mascara? Or can I ask for help? It's really important to know that there are counseling resources, peer support groups, and it's so important to stay engaged in various social communities, whether it's within the blindness related field or otherwise, because connection is key and community is so powerful. If a person were to look into vision rehabilitation, right? We've chatted about daily living skills, low vision assessments. And there are agencies, as I mentioned, across the country that do not just low vision assessments, but really comprehensive training. So folks can come for 2 weeks or longer, depending on a person's vision loss and goals, to receive comprehensive training so they can go back to work and work in a more competitive manner. I want to make sure that everybody knows that there are resources across the country. There may not be a lot of vision rehabilitation therapists, but we do exist across the country, as do low vision therapists. Cane use through the training of orientation mobility specialists exists as well. And the use of a cane is not limiting, but extremely invigorating, although scary, will allow you to travel with more confidence and be able to engage in that community. I have my notes right here, and those were my notes. You know, I ended a little sooner than I intended, but hey, there are my friends. Hey, Dr.
No problem at
Tieger.
all,
Hey,
Tina. That was
Michelle.
great. Thank you so much.
Yeah, of course.
That was really great, and I think we're gonna have a couple questions coming in on that too. Dr. Tiger, I'd love to chat about the two questions. I know you provided a quick answer through the chat, but I'd love to share those answers with the other individuals who may not have been able to view the chat. So the first question is, when is it appropriate to start taking
AREDS too.
AREDS2? I hope I'm saying that correctly. First sign, uh, first sign of Drusen. I
Drusen.
do apologize.
That's okay.
I
I
am
can go
not the
over
medical
it.
expert
I
here.
can go over that if it's easier.
Perfect.
The
Thank
first
you.
question was, when should we start taking AREDS 2 vitamins at the first sign of drusen? And the answer is no, not at the first sign of drusen. The AREDS 2 study actually only showed that it was effective once you had intermediate macular degeneration. And so there's a certain burden of drusen, the size and the number that are required before you should start them. Is there harm in doing so? No, but there's also not a lot of benefit, nothing proven. And so these are, expensive supplements. And so, you don't want to take them when there's, no proven benefit. The other question was, can you get blind spots from wet macular degeneration? And the answer to that is yes. You can get blind spots in the setting of an acute bleed. And you can also get blind spots if you develop fibrosis. So if you do have bleeding or neovascular membrane that grows and bleeds, and it's not treated or some are resistant to treatment, then you can end up with a scar, and that can also lead to a blind spot as a result.
Perfect. And Dr. Tiger, if we have some individuals on this session who, may still be trying to understand what the best treatment would be for them between these two options, what would you recommend? Kind of who should they turn to next?
Yeah, so I think this is a good conversation to have with your ophthalmologist, your retina specialist. General ophthalmologists don't administer these medications in terms of the injections of Syfovre or Izervay, but a general ophthalmologist can definitely talk to you about when it's appropriate to start the AREDS vitamins. I think these conversations, when it comes to the injections for dry macular degeneration, this requires some time and some real thought on both the physician and the patient's part, because these medications have significant side effects, like we talked about with the vasculitis, with the conversion to the wet form. And it's also a big burden on the patients to come in for these injections. So, making sure that the goals of care are aligning between the patient and the physician, and that, you understand, what kind of you're taking on by starting this process, and that you can also stop at any time. And so I think it requires, a discussion and some thoughtfulness. I usually don't start these injections on a first visit with a patient. I want to make sure that they think about it, understand the risks, the benefits. And again, I'm really, thrilled that Tina spoke to. I refer to low vision all the time because I think one thing you have to realize with these medications are, although it's great we have something approved, they don't stop geographic atrophy. They slow it down. And so, many of these patients will eventually lose their fovea, and it's important to have resources available to help adapt to this new vision. Again, you always have your peripheral vision, but loss of central vision is a big life adjustment. And so I think it's important to also explore those options. And, it's not the easiest thing to get into a low vision specialist, but there are, a lot in our area in Boston. We're lucky as compared to the rest of the country.
Absolutely. Yeah. And Tina, can I ask you to kind of talk about that as well? Just similar to what Dr. Tiger just mentioned, some individuals may think that it's one or the other. It may be treatment or low vision support. And, hopefully everyone here knows or is starting to know that that's not necessarily the case. So could you
Absolutely.
speak a little bit to that as well? What that might experience might be?
Yeah, absolutely. The two should really co-occur, or at least let rehabilitation or low vision optometrists or therapists take over after an initial diagnosis or treatment, so we can help fill in any gaps, right? Even if a person never loses their peripheral vision, the loss of central vision in a person's acuity can be really, can make it extremely difficult to continue to read, write, perhaps identify color, or complete daily tasks like cooking or cleaning. Navigation may remain something that feels, I don't want to say easy, but a little less impaired compared to, when you have the loss of peripheral, it can be really hard to walk when you only have central vision, and it's different when you have a lot of that peripheral vision. You can still see perhaps obstacles, but the use of a cane is not something that someone should feel isn't for them yet. You are still allowed to carry that cane to help identify any drop-offs or barriers. And it also allows other folks to know that if you're walking with your head perhaps tilted in a little, unique manner to view things a little bit eccentrically, as we say in our field, it allows people to know you're doing it for a reason, right? Like that you're trying to navigate in the world in your own way, and that you might need a little extra moment. So there's no reason that they can't all occur at the same time. We're all friends. We're all just here to make sure that, you get the best treatment and that you are living your life to the best of your ability.
Absolutely. I think we had a question come in kind of about what you were just sharing, so it might just add to your comment as well. Someone is asking, how do you go about finding a vision rehab service outside of large metro areas like Boston or other areas like that?
I always recommend starting with your state's agency. So I'll speak for Massachusetts. Our state's agency for the blind is called the Massachusetts Commission for the Blind. Each state has their own agency, Connecticut, New Hampshire, and so forth. And although a person may not be, quote, legally blind yet, it's still a really great resource to check out to see what resources they have linked on their website in terms of low vision clinics, where you may be able to see a low vision therapist or a low vision doctor, or any other resources they may have. For example, we have a store on our campus, and you may not know what different magnifiers exist. You may not know that, gosh, a self-threading needle is really helpful, so you can keep sewing those buttons and donning your socks if that is something that you choose to do. And there could be something in your town that you're just not sure of. I will also say two big resources that I always make sure I share is that there are resources for folks struggling to manage, label, and identify their medications. Nobody should ever question for a moment what medication they are ingesting or taking. We should always know and be really safe with our medication management. So please, anybody has questions around that, let me know. I know Michelle will be sharing my contact information. And I never want anyone to not have access to books. Literacy is key, right? And if you're ever struggling with reading or accessing print material, there are free talking book libraries across the country. So everybody should have access to their medication in a way that is accessible, and literature as well.
And as Tina mentioned, I will be sharing, all the resources mentioned today, including her contact information, in our follow-up email once the recording is available. And I encourage you to reach out to her. Tina does a really great job of helping you identify what are the best resources for you, even if it's not necessarily the Carroll Center. So I think that's a really great opportunity for anyone interested. Dr. Tieger, I think a question came in for you. Again, I do apologize if I completely mess up how you say this, but somebody asked if you can talk about keratosinus, and if it can be treated. Again, I apologize if that's not how you say it.
Sorry, I'm muted. I think what they're trying to spell is actually keratoconus,
Oh, gotcha.
which keratoconus is actually a cornea pathology. It's not a retina issue. And there are treatments for keratoconus. It depends on the stage of severity. There's corneal cross-linking, which you can do earlier, and the disease has become more popular. And ultimately, if you have scarring from very advanced keratoconus, you can have a corneal transplant done. But I think that's a much more in-depth discussion for another day, but there are treatments for keratoconus, and vision can be improved with keratoconus dramatically with rigid contacts as well. So that's something to see a cornea specialist and a specialized optometrist for sure.
Absolutely. It sounds, a big theme that you mentioned is staying in touch with your retinal specialist and continuing to, go to the experts as well. So that's really great. Tina, we had a question come in about low vision services. I believe you briefly touched on this earlier, but somebody did ask, since low vision services are not medical and not covered by insurance, who pays for them? Which is a great question. I know you probably get this at
Yeah.
least once a day. So
Yep, I do. So at our agency, if you are seeing our non-medical, right, or we're not medical professional, so it's not covered by insurance, our appointments, it's for 2 appointments, each just over an hour. It is $250 out of pocket that is paid by the consumer or the patients. If you were to go to NECO, New England College of Optometry, which I also mentioned, to see a low vision doctor, those are covered by insurance. If a person is legally blind in their, in our state, the $250 low vision appointment is free.
And this would be if they are registered with their agency
Yeah.
and they qualify as legally blind.
Yep.
Absolutely. Yeah. And so for further low vision services like an independent living program or other independent services like that, how would that work?
Ooh, all right. So if a person was interested in comprehensive training for going back to work or looking at just maintaining their independence at home, they can be anywhere from 2 weeks to 22 weeks, depending on a person's age, goals, and what have you. They are for consumers who are legally blind and registered with their state's agency. If a person is struggling with their vision and really wants more comprehensive training, we have had some folks who are on that cusp of legal blindness and are not registered, and they have paid out of pocket for training over the years. I wouldn't say it happens frequently, but it does happen from time to time.
Interesting. That's great. And Dr. Tiger, could you share a little bit from your perspective as a clinician what that process might be for someone to get registered as legally blind?
Yeah, so your ophthalmologist or optometrist should be able to obtain the forms and submit them actually on your behalf to the Mass Commission for the Blind. This is something we do routinely when patients meet the criteria, and it is your best corrected visual acuity, so your vision with glasses that we're going off of. And the criteria for Massachusetts is that you have to have 2200 or worse vision in your better seeing eye. That's different than the WHO criteria for legal blindness, which is 2400. So again, if you do meet this criteria, it's your optometrist, your ophthalmologist can submit these forms to the Mass Commission to the Blind for you.
That's great. Again, a lot of themes from you both about being in touch with your clinician and staying connected with your retinal specialists or your optometrists, because it seems like it's hopefully the first step to opening up a lot of resources to both treatments and services. It looks like those are mostly, oh, I think another question just came in. Let me just see. Um, what therapies are currently in field trials for dry macular degeneration? I believe that would be for Dr. Tiger.
Sure. So there's a lot in the dry pipeline, but I think most of the therapies are still going towards the complement inhibitor route. There's the Sienna trial that is currently up and running, actually, and it's in phase 3, and that is a systemic complement inhibitor, and so it's a subcutaneous injection under the skin as opposed to in the eye, and there's hope that it will have the same effect in slowing geographic atrophy as the complement inhibitors do with intravitreal injections. There's a little bit more thoughtfulness that has to go into patient selection because, again, this is immunosuppression and it's systemic. So patients have to have certain vaccines. There's certain medications, that you won't be eligible for if you're taking. And so, it might be a little bit more complicated as opposed to in terms of patient selection compared to the intravitreal injections. But that is a study that's up and running. And we're actually a site here at Tufts. I think we're the only site in Boston for it. And so that we'll be able to offer to patients as well.
That's great. Thank you so much. And it seems as though we've gone through all the questions. Thank you both so much for taking the time today to help us understand it from both perspectives. Although seemingly opposite, thank you for helping us understand that these two processes really go hand in hand. For everyone else, thank you so much for tuning in. If you are interested in this ACVREP credits, the exit code is MOON, MOON. So please do email development@carroll.org by the end of day and include the entrance code I shared earlier, as well as the exit code MOON, MOON. And I will be in touch. Our team will be in touch hopefully in the next day or so with the recording of today's session and all of the resources that were shared today by both Dr. Tieger and Tina. Both of you, again, thank you so much. Thank you to the Apellis team for helping us make today possible. And we are very grateful for everyone's participation.